Welcome to the next sessions. We're going to have a very prominent international professor to give us a talk on update on Parkinsonism. The coming speaker is Professor Peter Jenner. He is a well-known international specialist in preclinical aspect of neurodegenerative disease, notably Parkinson's disease. He spent his most part of his career at King's College of London, where he was head of pharmacology for 14 years before he returning to his research roots and subsequently becoming emeritus professor of pharmacology. He has more than 1,000 publications, and he's been awarded with various honor and fellowship. I don't think I will spend more time to introduce it. Otherwise, it will spend another hours and you will miss his lecture. Instead of further introduction, I would like to join me to hear his updated lecture related to Parkinson's disease. Can we start the presentation now?
Hello, everybody. I'm Peter Jenner. I'm Emeritus Professor of Pharmacology at King's College in London. And thank you very much for inviting me to do this presentation. Because you're an audience of informed patients and carers and an audience of also treating physicians, what I thought I'd do is a broad brush approach to what's happening in Parkinson's disease. And hopefully what I'm going to do is I'm going to provide something that's of interest to everybody in the room. And I, of course, at the end will welcome any questions that you might have about anything I'm going to present, or indeed anything else to do with the treatment of Parkinson's disease. So first of all, I have to show you this. I have to show you my disclosures. I don't think there's anything of relevance to the presentation in what I'm showing you here. I think the only thing to point out is that what I'm going to do is I'm going to give you a very personal view of what's going on in Parkinson's disease. And of course, this may not be the same view as the organizers of this meeting, or indeed yourselves. And I'll be happy to debate that with you at the end during the discussion period. So what am I going to talk about? Well, here's a long list of things that I hope to cover. I really want to talk a little bit about Parkinson's disease itself to start with. What I want to do, and you'll get the emphasis of this from the red box that I've put on this slide, is I want to try and sort of move away from dopaminergic approaches to treatment, and I want to look at some of the non-dopaminergic approaches that are taking place. And also I want to look at what we should be doing for non-motor symptoms of the illness rather than just for motor symptoms. And then I'm going to move on and say, hopefully, a little bit about what we're doing at the moment to try and produce a treatment for the disease itself rather than just for the symptoms of the disease. Now, the first thing I want to emphasize is based around this slide. When I started research into Parkinson's disease, this would have been the classical definition of the illness. And this is still very useful from a clinical diagnosis of Parkinson's disease perspective. And so we've always viewed Parkinson's disease as basically being a movement disorder characterized by the cardinal symptoms of slowness, stiffness, tremor, postural abnormalities, and we attribute the disease to being due to the degeneration of dopaminergic neurons in the basal ganglia and the subsequent loss of striatal dopamine content. And that's what we've made the focus of treatment of Parkinson's disease, in other words, dopamine replacement therapy. But what's happened is we have moved a very long way away from this classical teaching of the illness. And I think this slide, which is now some years old, it encapsulates what we think about Parkinson's disease in the modern era. The first thing that this shows you is that Parkinson's disease is not just a movement disorder, that there are many non-motor components to Parkinson's disease. For example, loss of sense of smell, sleep disturbance, neuropsychiatric complications, autonomic changes, all of these are part and parcel of what we now describe as Parkinson's disease. But the other thing we've realized is this is a progressive disorder in terms of the way in which these symptoms appear. And it looks as though non-motor symptoms of the illness may well occur many years, if not decades, before the onset of the classical motor symptoms of Parkinson's disease, whereas non-motor symptoms can, of course, also occur after the onset of the movement disorder. So this is a sort of complete change around from what we classically think about in Parkinson's disease. And what this is a recognition of the complexity of the biochemistry and pathology of Parkinson's disease. And I think we all accept now that this is an illness that affects many different areas of the brain, both pathologically and biochemically, and that many of the changes which occur are nothing to do with dopaminergic systems. These are changes occurring in non-dopaminergic neuronal systems throughout the brain. And one of my views, at least, is that there is no single pattern to the changes which occur in Parkinson's disease. These are sweeping changes. There's no single origin of the pathology, and there's no single pattern to the way the pathology progresses through the brain during the course of the illness. And the other thing I think that's also become clear is it's not just a brain disorder, Parkinson's disease, because if you start to look for pathological and biochemical change in the rest of the body, if you go to the periphery, for example, if you look for evidence of deposition of the protein Alpha-Synuclein, which we think is a marker of Parkinson's disease, then what you find is that deposits of Alpha-Synuclein are found in the GI tract, they're found in the heart, they're found in the bladder, you find them in all sorts of ganglia, you find them in the skin. And what this is telling us, I believe anyway, is that Parkinson's disease, rather than just being a brain disorder, in fact, is a complex systemic disorder with multiple organs being affected by the pathology and subsequent biochemistry of the process that underlies Parkinson's disease. And to just add another layer of complexity to all of this, I think the other way we're going to think now that Parkinson's disease is it's just not a single disease. Everybody with Parkinson's disease is different in some way, and I think that we're increasingly recognizing Parkinson's disease as being a syndrome rather than an illness. And I think we've known this for some time, because those of you who treat Parkinson's disease will be very aware of the different clinical presentations and the possibility of different genetic backgrounds. We have the classical late onset Parkinson's disease versus cases of early onset illness. We have patients where the disease process seems to progress rapidly, whereas others have a very slow evolution of the illness. We have those people who have a pure akinetic rigid form of the disease, and we have those who have tremor dominant forms of Parkinson's disease. And of course, you'll all be aware of the very different response to drugs that you see in individual patients with Parkinson's disease. So clearly this is a complex sweeping illness that goes through the peripheral and central nervous system, and that manifests itself in different ways. And these different ways just don't involve only dopaminergic systems, they extensively involve non-dopaminergic neuronal systems and neurotransmitters other than dopamine. And that brings me to drug treatment. Now, as I pointed out earlier, and as you will be well aware, the treatment of Parkinson's disease is basically centered on dopamine replacement therapy. But although this has been an absolute revolution in the treatment of the illness, and which we've had now for some 60 years, the discovery of the dopamine loss, the ability of levodopa, L-dopa to replace dopamine in the brain and to reverse the changes in motor function, although this was an absolute revolution, what it has done is in some ways it's made us very focused just on the dopaminergic system and just on the basal ganglia. And what it's done is it's really made us have stereotyped approaches to our thinking about Parkinson's disease, which I don't think are warranted by the current concepts that we have of this being such a broad brush, sweeping, diverse illness. And I think the other thing it's done is that if you look at the treatment of Parkinson's disease, it's become what I call like a comfy old jumper. It's become like something that we're just very comfortable with, and we haven't had to think really outside the box other than thinking about levodopa, dopamine agonist drugs, the various types of enzyme inhibitors, the MAO inhibitors, the COMT inhibitors. And I think we've got ourselves into a bit of a rut as far as therapy is, even though it's been such a revolution in terms of motor function. And if one's basically honest, most of the additions to oral therapy of Parkinson's disease have been what I would call I-dotting and T-crossing in nature. In other words, they've been small steps forward, but they haven't provided us with the big jumps in treatment that we need. And it is difficult to see how much further progress we are going to make using novel oral dopaminergic approaches to treatment. But we have done one thing very well in the dopaminergic area. That is, we have gained an advantage from the basic science and from clinical experience in the way in which dopaminergic drugs are administered. And I think what we know is that the more continuously we deliver dopaminergic medication in Parkinson's disease, the better the outcome as far as the control of motor function is concerned, and also as far as avoiding the onset of motor fluctuations like wearing off, or motor complications like dyskinesia. So there's been a big move to use technology to provide dopaminergic therapy in Parkinson's disease over the last couple of decades. And of course, a great example of this is the continuous delivery of levodopa to its site of absorption in the upper small intestine. So this would be a continuous intrajejunal infusion of levodopa carbidopa, such as you get with the duodopa system. And this has proved a great advantage in treating advanced cases of a Parkinson's disease where there are severe motor fluctuations and dyskinesia. And there's no doubt that continuing to deliver levodopa on this basis increases on time, decreases off time, and it may decrease the intensity of established involuntary movements. And this is something which is clinically effective, expensive, but increasingly utilized, although it is invasively and technically challenging to some degree. However, this is still an oral therapy, and the other thing that's happened is that we're starting to think about the future in terms of non-oral drug delivery. And if you look at what's going on in Parkinson's disease, there's increased use of technology to try and provide continuous dopaminergic drug therapy through other routes rather than the oral route, for example, by subcutaneous infusion of apomorphine, for example, which is already in existence. You can use the transdermal route to deliver drugs on a continuous basis. And increasingly, as I'm going to show you in a moment, there may be other ways of delivering for example, by a non-oral route, which is going to provide a more continuous therapeutic approach. And that's the sort of last bit of this section of the presentation that I want to share with you. This, for example, is just one of the approaches which is being clinically trialed at the moment. This is from the company AbbVie, who have discovered a novel soluble form of levodopa and carbidopa. So this is a prodrug of levodopa and carbidopa, which is very, very soluble. And what this does is it allows you to use small volume pump approaches to its delivery. And what they're doing is they're using subcutaneous infusion of levodopa after which the prodrugs are converted to levodopa and you get stable levodopa exposure. And this is something which is going to be much less invasive than the current duodopa system. And this is something where the best drug for the treatment of Parkinson's disease might be available much more readily, I think, at various stages in the illness on a continuous drug delivery basis. But despite all this dopaminergic medication, despite everything that's gone on for the last several decades, we still have major therapeutic challenges in treating the symptomatology of Parkinson's disease. We still have the loss of drug efficacy that you get with disease advancement and with the duration of drug therapy. We still have the problem of motor fluctuations and motor complications. We have adverse events from the dopaminergic drugs themselves. We have impulse control disorders, hallucinations, cardiovascular changes. But one of the things that we haven't really got to grips with, I'm going to try and explain to you why, is we haven't got to grips with the non-dopaminergic symptoms of the disease, which are the ones which are so prevalent when you get motor function under control. So we haven't got a handle on gait or ataxia or freezing or falls or even tremor. We haven't got a handle on many of the peripheral and central non-motor symptoms that occur, the neuropsychiatric complications occurring with Parkinson's disease remain a problem. Now, the interesting thing about all these, from at least my perspective, is that we're talking about two things. We're talking about non-motor symptoms as being a major problem, and what we're talking about is non-dopaminergic components to the problems that are the therapeutic challenges for Parkinson's disease in the future. And I just want to show you that these may be in places that you wouldn't really expect. So let me just show you something that we've been working on very recently. And this relates to wearing off in Parkinson's disease. Now, you would think, well, wearing off is to do with dopaminergic drugs, it's to do with dopaminergic. It's a very common problem in Parkinson's disease. It's something which affects the quality of life of people with Parkinson's disease, and that consistently needs treatment as the illness advances. And what we invariably do is we say, well, if we deliver the dopaminergic drugs more continuously, what we do then is we overcome the shortcomings of oral dopaminergic therapy, where you get fluctuations in plasma levels of drugs and fluctuations in treatment response. And what we do is we say, okay, let's adjust dopaminergic medication, oral dosage change, add an adjunct, an enzyme inhibitor, introduce an advanced therapy, and that's the approach to wearing off. But I just want to point something out to you. And let me point this out to you, which we're just submitting for publication. That is, if you go to the advanced therapies, if you start to look at duodopa, if you look at apomorphine subcutaneous infusion, if you look at rotigotine, transdermal administration, if you look at all the ways that we try to deliver drugs continuously, what you find is, in fact, that while you reduce off periods persist after all these delivery routes. And when you analyze all of these delivery routes side by side, what you can do is you can work out why off periods persist. And the only commonality between these treatments that explains off periods is that the remaining off periods are actually non-dopaminergic in nature. And that's another reason why we need to get away from just focusing on the dopaminergic treatment of Parkinson's disease. And this goes a little wider as well. If you start to look at non-motor symptoms in general, then there's this paper by Ray Chowdhury and Tony Shapira. It's a very nice paper. It looks at the dopaminergic component of non-motor symptoms in many respects. But what it shows is that some non-motor symptoms show some improvement to dopaminergic medication. But what it's also telling you is that clearly dopaminergic treatment is not the whole answer to the problem of non-motor symptoms. And if we move on a little more and we go on to the advanced therapies, if you start to look again at apomorphine subcutaneous infusions, if you look at levodopa, if you look at levodopa intraduodenal infusion, if you look at rotigotine transdermal patch, so go to continuous therapies, again, all of these improve some components of non-motor symptoms to some extent, but none of these have an effect that controls non-motor symptoms to the level that's required. And clearly, dopaminergic treatment is not a whole answer to non-motor symptoms. So what do we do about this? Well, the answer is we start to look for non-dopaminergic targets related to the pathophysiology of Parkinson's disease. And what we have to accept is the widespread pathology and biochemistry of Parkinson's disease. Now, if you look around the brain as a whole, then what you immediately see is that Parkinson's disease is not just the degeneration of dopaminergic neurons. You get the marked degeneration of adrenergic neurons, serotonergic neurons. You have changes in GABA, glutamate, histaminergic, opioid, cannabinoid. You have multiple changes in the brain as a whole in Parkinson's disease. And it's in all probability that these non-dopaminergic changes are the ones which are responsible for the non-motor symptoms and to some degree the motor symptoms of Parkinson's disease. And if you go into the basal ganglia itself, which you have on the left-hand side of this slide, then if you just take dopamine out of the system, so you lose the nigrostriatal dopaminergic neurons, then what this does is it has knock-on effects on all the circuitry that makes up the striathalamocortical loops that control voluntary movement. So you have changes in all sorts of other neurotransmitter systems, the cholinergic system, the Gabaergic system, the glutamatergic system, lots of systems. So there's a lot of opportunity in here for manipulating other systems that are important in motor and non-motor symptoms of Parkinson's disease. But the question is, how easy is that to take and turn into a therapeutic advance? Well, what's been happening experimentally is what's shown on this slide. From a basic science perspective, what we have been doing is working our way round the brain system by system and looking at the value of manipulating each of the neurotransmitter systems that are affected by the pathology of Parkinson's disease. So we've worked our way around the brain and we've looked at the serotonergic system, the adenosine system, the histamine. We've looked at most of these systems now in experimental models of the disorder. And what we found is we can show some positive effects of manipulating these systems on both actually motor and non-motor systems. And what we're starting to get is at least some translation to Parkinson's disease. And what we're looking for is efficacy of these non-dopaminergic approaches without the presence of the dopaminergic side effects that currently blight dopaminergic therapy of the illness. And there is, to be fair, a number of clinical trials continuing which are looking at these non-dopaminergic approaches. But I want to do one thing. I want to point out to you, because I know people get impatient about when new treatments are coming, I want to point out to you, this is not easy, and it's not something which is going to be an alteration in therapy overnight. And for example, if we move away from the dopaminergic system and we target, for example, cholinergic neurons, so acetylcholine as a neurotransmitter, then we know in the basal ganglia that there are nicotinic receptors for acetylcholine and there are muscarinic receptors for acetylcholine, and we know that they have an important controlling influence on the systems that are responsible for running the motor programs for voluntary movement. Now, we've tried manipulating the nicotinic system, and to be quite frank, I don't think we've got very far for proving any efficacy on motor symptoms. And what looks much more interesting is manipulating muscarinic cholinergic receptors. The difficulty is these come in various subtypes, M1, M2, M3, M4, all of which are present in the basal ganglia. And what you really want to do is manipulate these systems individually to find out which one is functionally important. And the difficulty is that there's very little ongoing research within the pharma industry for looking at this important neurotransmitter system in Parkinson's disease. And despite pushing for some time, it's been almost impossible to ask pharma companies to try and attack this as a target for Parkinson's disease, even though some of them have interesting drugs already available sitting in their cupboard. And what we're left with is the old-fashioned anticholinergic drugs for Parkinson's disease, which are non-selective in nature, which affect muscarinic receptors of all types, which affect muscarinic receptors all over the brain and the periphery, which can be clinically useful, but unfortunately lead to dry mouth, blurred vision, urinary retention, cognitive impairment. So while we know this is a target, attacking it is not easy. And the same applies if you look at Gabaergic systems in the basal ganglia. We know that the major output pathways from the striatum, the direct and the indirect output pathway, are both Gabaergic in nature. We know the balance between them is altered in Parkinson's disease and in dyskinesia. But think, because of the importance of these systems, there would be attempts going on to modulate the Gabaergic system, to modulate GABA receptors, the GABA A or the GABA B receptor or the benzodiazepine receptor. But this has not been the case. And you have to go back a very long way to find any attempts to manipulate Gabaergic function. Baclofen was tried, Progabide was tried but not developed. And what we have is another target which is yet to be exploited for the benefit of Parkinson's patients. And I'm afraid the same applies to the glutamatergic system. Glutamate, as I will come back to in a moment, is an important neurotransmitter in the control of motor function in terms of the striothalamo cortical loops that are responsible for this. And we have had multiple attempts to try and alter glutamatergic activity, which we believe to be, in general, overactive in Parkinson's disease. And we have tried to manipulate all types of glutamatergic receptors, and we've tried to modulate glutamate release. And what we've unfortunately had is we've had efficacy of these types of approaches in experimental models of disease, but when translated into humans and into clinical trials, what we usually find is there's a very narrow therapeutic window, a dose below which you get no therapeutic effect, then you get a very narrow window of doses where you can see a therapeutic effect of these changes, but any higher dose then produces what I can only describe as nasty side effects. And the reason for this is we're yet to find one glutamatergic receptor that has a selective localization within the pathways that we're interested in, rather than being widely distributed in the brain. And the result of that wide distribution is that when you manipulate glutamatergic function, what you get is adverse events arising because you're affecting not just the basal ganglia, you're affecting glutamatergic systems in the cortex, in the cerebellum, and elsewhere. And at the moment, it's only the good old-fashioned weak NMDA receptor antagonist, Amantadine, which we've had for more than 40 years, which is the only approved glutamatergic drug for PD. And this again is a target which is crying out for a greater push for drugs which are going to be efficacious in Parkinson's disease. Now, that all sounds very depressing, and to some extent, I suppose it is. But we have got glimmers of hope from the non-dopaminergic area. And one I'll move to very quickly is to look at the serotonergic system. And the serotonergic system and changes in particularly serotonin 2A receptors have been associated with the visual hallucinations that occur in Parkinson's disease and indeed in Lewy body dementia. And so what we have is a clear target for the manipulation of serotonergic function associated with a persistent and so far relatively untreated side effect of the disease and its current dopaminergic therapy. And what that's done is it's led to the introduction of this drug, Pimavansarin, for psychosis in Parkinson's disease. And this drug is a 5-HT2A inverse agonist, or you can call it an antagonist. It's a very selective drug devoid of effects on dopaminergic, histaminergic, adrenergic, or muscarinic receptors. And what Pimavansarin can do in Parkinson's disease is it can improve hallucinations and delusions without worsening motor function, and it seems to have reasonable efficacy in the treatment of Parkinson's disease. And this, I think, is just one example of what might be feasible in the future in going away from the dopaminergic system and using non-dopaminergic approaches as the way forward in treating Parkinson's disease, rather than just relying on the use of dopaminergic medications, which we've done for so long in the past. Now, I said something about the glutamate system earlier. I said the glutamatergic system was important, and I actually said I was going to go back to it a little bit later on. And I want to go back to it because I've got a view that the way in which we're approaching non-dopaminergic approaches to Parkinson's disease, the way in which we're trying to develop drugs through non-dopaminergic mechanisms, might not be exactly the right way to go forward. And what I want to do is I want to use one specific example. And so what I want to do is I want to just look at the glutamatergic system. And I've already pointed out to you that glutamate is a major excitatory neurotransmitter in brain, that we have multiple glutamate receptor subtypes, which I've mentioned, and we've tried to manipulate individually in Parkinson's disease. And I've pointed out also that we know that glutamatergic transmission is altered in Parkinson's disease and in dyskinesia. But we haven't succeeded in encompassing all of this information into a viable treatment. But maybe that's because of the way in which we're doing it. Now, what might be more feasible is that if you are looking at a disease where there are multiple neurotransmitter changes occurring, all of which interact to cause the motor and the non-motor symptoms of the illness, maybe it is not the best way to try and manipulate these systems one by one. Maybe what you need to do is modulate more than one neurotransmitter system at the same time, and hopefully through the same drug. So because this is a multi-neurotransmitter, multi-pathology disease, and the symptoms of Parkinson's disease reflect the complexity of those changes, maybe what we need to do is move away from highly targeted single action drugs and get back to what we used to call dirty drugs. So drugs which have a rich pharmacology, so they have multiple pharmacological actions, and which you need to treat multiple symptoms of Parkinson's disease using a single therapeutic approach. And what we would say now is not dirty drug. We say rich pharmacology or multimodal in nature. Now, have we got any examples of this? Is there something going on which will help us understand whether this is viable or not? And for that reason, I want to turn to this drug, which is available in many countries, and that is Safinamide. Now, Safinamide was introduced as a reversible MAO-B inhibitor. And you can say, well, that's fine, but actually, do we really need another MAO-B inhibitor, as we have prasagiline and selegiline already, even though they're irreversible in nature? Well, that's MAO-B inhibition is probably not the most interesting bit of Safinamide. The most interesting bit about Safinamide is this is a drug which has a lot of additional pharmacological and biochemical effects. One of the most important of those effects is that this drug is also a sodium channel blocking drug. Now, why is that important? It's important because the state and use dependent sodium channel blocking actions of safinamide give it the ability to turn off glutamatergic neurons and inhibit abnormal glutamate release without depressing glutamate release below the normal physiological level. And this may be the reason why safinamide appears capable of normalizing activity in the loops that control voluntary movement. So this is a drug now proven to enhance the effects of dopaminergic medication through its MAO-B activity, but at the same time suppressing excessive movement in the form of dyskinesia. So what we have is, instead of a single action drug, which is what we've been looking at for a very long time in Parkinson's disease, is we have a drug that now targets two key mechanisms for improving the treatment of Parkinson's disease: MAO-B inhibition to enhance dopaminergic function, and inhibition of glutamate release through sodium channel blockade, which is probably the mechanism through which this compound inhibits dyskinesia at the same time as improving motor function. And what it does is it differentiates safinamide from the other single action compounds which are already around. So selegiline and rasagiline, they're also MAO-B inhibitors, but they only have that as their single action. And sure, they potentiate dopaminergic transmission and are clinically very useful. We have amantadine, which only acts on the glutamatergic system. So it's a weak NMDA receptor antagonist, and that's fine, another clinically useful compound. But what we now have in safinamide is a compound which has both of these activities, inhibits glutamate release, and so it has a dual mechanism of action, and that can only be of advantage. And indeed, there's some evidence that safinamide might have effect on some non-motor symptoms of Parkinson's disease. Now, safinamide is not alone in this, and I just want to continue for a moment with this multifunctional use of safinamide and the fact it has a multimodal activity. Now, safinamide is another drug which has been repurposed for Parkinson's disease based on its multimodal activity. Now, many of you will know safinamide as a drug which is used in the treatment of epilepsy, but certainly in Japan and in other countries, safinamide has been put into clinical trial for Parkinson's disease. And what it's found is this is an effective adjunct to levodopa treatment, but it has a low incidence of dyskinesia and of psychosis. But the interesting thing about safinamide is it's a drug that does have some action on dopaminergic systems, but it also inhibits striatal Gabaergic transmission, which we've failed to do so far. It also inhibits sodium and calcium channels, and what that means is, among other things, it will affect glutamate release. So here's another multimodal, multifunctional drug that's being shown to be effective in Parkinson's disease. And if we go back to good old amantadine, which I talked about before, then in fact, I talk about amantadine as being a weak NMDA antagonist, but in fact, that's not really quite true. Amantadine's anti-dyskinetic effect may be mediated by its ability to block NMDA receptors, but amantadine also has effects on dopaminergic mechanisms, which probably explains why it's a good symptomatic treatment. And amantadine also has the ability to inhibit cholinergic, serotonin, and noradrenergic mechanisms, and that might explain the broad-based, wide use of this compound over several decades. It's another old-fashioned, dirty drug that is now being looked at as being multimodal. And with that, I want to move away from symptomatic treatment, and I want to finish in the next few slides by looking about what we can do for the disease process rather than treating the symptoms of Parkinson's disease. And there's clearly three things we can do. We can try and produce neurorestoration, so restore or reverse neuronal loss in Parkinson's disease. We can try and use disease modifications to slow the natural progression of the disease. And we can try using neuroprotection, stopping the onset of the disease process or arresting its progression. And all of these terms refer to drugs which will have an effect on the disease process, although they sometimes are a little mixed in the way in which they're used, because to some extent they all have different meanings for the approaches that we can use. Now, the bad news is I don't think we've been very successful in doing this so far. If you look at this review, which was published some 8 years ago, then 38 clinical trials were reviewed of neuroprotection or disease modification in Parkinson's disease, and this number's grown over the intervening years. The bad news is that none of these clinical trials proved to be effective in altering the natural course of Parkinson's disease, and they involve a whole range of different approaches, as you can see from the list on this slide, and they were all backed up by preclinical evidence of a neuroprotective disease modifying effect. So we, in essence, have had no translation from the laboratory to the clinic, and I think we have to look at why that is and the approaches which we're using. Now, a recent victim of the attrition has been inosine. Inosine is a precursor of uric acid, of urate, and it was quite clear that in Parkinson's disease there are higher urate concentrations associated with a slower rate of progression of Parkinson's disease. So the idea was to supply inosine, increase urate, and see whether that decreased the rate of progression of the disease. And certainly giving inosine increases serum urate levels. The difficulty is, yet again, there was no evidence that this had any effect on the disease progression, at least as far as this clinical trial is concerned. So what else can we do? Well, one of the things we've been doing is we've been trying to repurpose existing drugs from other therapeutic areas. Now, why are we doing this? And the reason we're doing this is to develop a neuroprotective drug is a high-risk strategy, as you've just from all the failure we've had. It's also a very long process. It can take 15 years from discovering a molecule to producing a medicine. It's extremely complex and very expensive. Now, if you can take a drug that already exists and is safe to use in humans, that's in another therapeutic area, and move it to Parkinson's disease, you can shorten this process. You make it less risky, less cost, and you can also be sure that you're not going to get unwanted side effects because the drug is already in use in humans. And this is going on quite extensively in Parkinson's disease. We're using drugs from diabetes, particularly drugs for type 2 diabetes. We're using a whole range of other drugs, for example, antihypertensives, some anti-cancer drugs are being studied, some antimalarials, some ion chelators. There's quite a lot of clinical work going on, all under clinical investigation at the present time. And there's a little bit of hope coming out of some of these. For example, exenatide might have some effect on some components of Parkinson's disease. And there's a view that isradipine as an antihypertensive might also have some effect on some components of the disease process. And so this is another string to our bow in terms of what we might be able to do. Now, what else can we do? Well, there are other approaches which we can usefully use. We've been trying fetal dopaminergic cell transplants for quite a long time, but there's a move back to using fetal dopaminergic cells, again, restoring dopaminergic transmission. This is based on a better approach to this application than we had when it was first introduced into potential therapy. We're looking at stem cells, which I'll show you a little more in a moment. We're looking at gene therapy for inserting genes for dopamine production, and I'll show you again a little more of that in a moment. And we're also looking at gene therapy for putting in the genes for the expression of trophic factors such as GDNF. Now, with stem cell approaches, everybody's very interested in stem cell approaches. Well, they're very interesting. I think probably induced pluripotent stem cells are the best way of going forward in this, but there are embryonic stem cells and mesenchymal stem cells as well. There's a good science base for using stem cells, But we've seen improvement in experimental models, but what we need now is for clinical trials to start going forward in a big way. There's some limited clinical work underway, but we have to have some slow progress in this area to see whether it really will work and will have an effect, in this case, on dopaminergic components of Parkinson's disease. But we have to be careful because there are the possibilities of tumorigenesis, for example, and we need to have extensive safety studies to show this is safe and effective before it can be rolled out into the Parkinson's population. Also have attempts going on to try and put back the genes for dopamine production into the striatum. There's 3 key enzymes involved in the production of dopamine. There's aromatic amino acid decarboxylase, tyrosine hydroxylase, and GTP cyclohydrolase. You need all of these enzymes to lead to dopamine synthesis. And this is being encompassed into some viral vector mediated gene delivery. And again, this is looking promising as far as the future is concerned. And I thought I'd just show you this example, which is Prosavin, which comes from a British company, Oxford Biomedica. They have put all 3 of the genes for these enzymes into a lentiviral vector. They've been working on this for some time. They've shown that you can produce improvements in motor function in MPTP-treated primates, probably our best model of Parkinson's disease. But what they haven't been able to get so far is a sufficient enzyme expression for this to be something which is likely to be effective in man. And what they're doing now is they're using a new optimized vector, OXB102, which is going to improve that enzyme expression and may allow dopamine production to be reintroduced into the Parkinsonian brain. And there have been some phase 1, phase 2 studies of this basic approach in Parkinson's disease, and there have been some evidence of improvement in motor scores up to a year after treatment. And I think what it needs now is to show whether these moderate improvements can be improved with the new vector and made into something which is clinically highly effective. So perhaps the last thing I want to get to is alpha-synuclein. Now, we've been fixated on our alpha-synuclein as being a protein that's highly toxic to neuronal systems in Parkinson's disease since 1997. So we've been fixated on this for some 25 years, which gives you some idea of how long it takes to develop neuroprotective neurorestorative therapy. And we got interested in alpha-synuclein because it was identified in cases of familial Parkinson's disease as being a toxic, potentially toxic component of the pathological process. And the reason we're interested in it is alpha-synuclein is present in most forms of Parkinson's disease. Lewy bodies, the pathological hallmark of Parkinson's disease, are packed with alpha-synuclein. Gene mutations lead to mutations in alpha-synuclein that lead to various forms of Parkinson's disease. And in the laboratory, there are bits of alpha-synuclein which are highly toxic to dopaminergic neurons. Although I have to say, I don't quite understand what causes altered handling of alpha-synuclein in general in the Parkinsonian population. And as a result of this, what we've had is that we've started to see the introduction of humanized monoclonal antibodies targeted at removing aggregated forms of alpha-synuclein from plasma and from brain in Parkinson's disease. And this is an example from the drug company Roche. And what they've found is that using this monoclonal antibody approach, you can, at least in the laboratory, show that you can reduce the levels of alpha-synuclein, reduce the toxicity of alpha-synuclein. And it has been examined in mild to moderate idiopathic Parkinson's disease. And you can show that this approach does reduce the levels of alpha-synuclein in certainly in serum. The difficulty is these studies have now become stalled at the phase 2 level because at the moment we're seeing the removal of alpha-synuclein, but I don't think we're seeing the efficacy that we expect. And my worry is that we may be highly focused on this one protein and it may not be the cause of Parkinson's disease that we hope it will be. So in the last 2 minutes, what I really want to do is just make a couple of other points. The first point I want to make is I think we're doing the clinical trials in Parkinson's disease incorrectly. I think at the moment, because we just generally recruit patients into Parkinson's disease based on the clinical diagnosis of a movement disorder, and we then just divide them into placebo groups and active treatment groups, and we give them drug for, say, a period of 12 months, and then we look at whether there's been a change in the rate of progression between the two groups. I think we're doing this the wrong way, because if we accept that Parkinson's disease is not a single disease, it's a syndrome, then what we're doing is we're recruiting patients with different forms of Parkinson's disease into these clinical trials. And what we're not looking for is an effect of these treatments on individual forms, subtypes of this. And it may be that if we're more discriminating in the way in which we recruit patients into clinical trials, and then we might see that some patients with Parkinson's disease get better with some of these treatments. And I think it's using the herd approach to recruitment, which is misleading us as far as Parkinson's disease is concerned. And I think the thing I would emphasize to you is that if Parkinson's disease is a syndrome, then don't expect a single treatment to work in everybody. If there are different patterns of pathology and biochemistry, different types of PD, there's no single cause or pathogenic mechanism, it's very unlikely that classical clinical trials are going to show you something which is effective, and it's very unlikely we're going to find one drug that is appropriate for all patients with Parkinson's disease. And what I would do is, in the final few seconds, is I would ask you to take a step backwards and actually look at a different approach. And what I think we might do is learn from the treatment of multiple sclerosis. And what they've learned to do in multiple sclerosis is not treat it as a single disorder. Look at the type and rate of disease progression that you have in multiple sclerosis. Understand the basis of the disease. Not look for one drug fits all. Have multiple targets and personalized medicine. And I think they've made much more progress in treating multiple sclerosis than we've made in Parkinson's disease for exactly this reason and the approach they've taken to the illness. So the conclusion of all this is that we've got good treatment for Parkinson's disease, but we are bogged down in dopaminergic approaches to therapy. There are non-dopaminergic components to both motor and non-motor symptoms of the illness. We've got multiple targets to attack within the basal ganglia and elsewhere, but we need to get on with it. And we've got to find the right target, as it's not easy to find a target which has the specificity and selectivity that we require for the basal ganglia. We need to move to multimodal drugs, and that's a good way forward. Now, finding a disease-modifying or neuroprotective approach is difficult. The next advances in treatment will probably come from cell-based therapies, gene therapies, or monoclonal antibody-based treatments, and we need to take a big picture view of Parkinson's disease and not be blinkered and simplistic, looking at it as a single disease based around the basal ganglia and dopaminergic loss. And with that, I thank you for your attention. I thank you very much indeed for inviting me to do this lecture, and I'm very happy to take any questions that you might have either now or later by email. Thank you very much indeed.
Thank you very much, Professor Jenner. It's an excellent talk, bringing us from the old view of Parkinson's disease being a dopaminergic origin to now updated research and potential treatment for a complex neurodegenerative syndrome. Okay, I think it's the time for Q&A. As the chairman, I have the advantage or the priority to ask the first questions. And my question is, you already mentioned no single patients will be similar. We should be personalized the treatment. But in general, will you suggest we should start with a multimodal drugs when the patient's being diagnosed with Parkinson's disease in the early stage?
Okay, I think that basically there's no algorithm for treating Parkinson's disease in general. I think as experienced clinicians, you have to sit there and you have to treat what you see in front of you. And if you see something which is what I would call simple Parkinson's disease, then you can take a simple drug treatment approach to that particular individual. But if you have a more complex case, then I think you should consider using a multimodal drug for that individual. And what I've found in the United Kingdom is quite interesting. I'm not sure how your medicine works in Hong Kong, but we've had more buy-in from the geriatricians, from the care of the elderly people in using multimodal drugs than we have from our neurology colleagues. And that's probably because of the way in which patients present, and the older patient presenting not only with Parkinsonian symptoms, classical Parkinsonian symptoms, but probably with a range of comorbidities. And the geriatricians have been more easily convinced that they should be using multimodal drugs to avoid polypharmacy in these older patients who have multiple symptoms on presentation. So no, I don't think there's any rules, and I think you as a good Parkinson's doctor sort it out on an individual basis. And I'm pretty certain that in the next talk that's coming along, Ray Chowdhury, my colleague Ray Chowdhury, is really going to emphasize the way in which you can subtype people with Parkinson's disease and the way in which you can personalize medicine for these individuals.
Thank you. Okay, I don't have any questions on the list yet.
That's the problem with being chairman. You have to listen and think up all the questions. I think it's the that's the bad job.
Yeah. Okay. The joke is no people like me. That's why they don't send me the questions. But the reality is your talk is so excellent and so clearly presented. That's why everyone got your message. And
I think you've got one on the screen now. Yep, I can see one.
I just got it one now. Thank you, Professor, for introducing the concept Parkinson's syndrome. But can the syndrome concept just reflect the progression of the synchronopathy to different regions and circuits of the brain?
Yeah, it might do. But I think we've sort of got into a mindset where everybody shows this lovely slide by Braque and colleagues, where they show this progression of synucleinopathy from the periphery to the brain stem to the midbrain to up to the cortical regions. And I think we've got into this mindset of thinking there is only one way in which Parkinson's disease progresses pathologically and biochemically through the brain. I think that's wrong. I think, and I think Ray Chowdhury in a moment will emphasize this, it can probably start from various points within the brain, which is why the early non-motor symptoms, the pre-motor symptoms can vary, and then it can progress through the brain in different ways. So it may be related to alpha-synuclein, but whatever the pathological process is, I don't think there's a single picture. I'm almost ashamed to say I've spent almost 50 years working on Parkinson's disease since my early career through to now, and I have become increasingly convinced during the course of my career that this is a disease that is a syndrome. I've been increasingly convinced that there is no single cause of Parkinson's disease. It's not all alpha-synuclein. It's not all stuff that comes from the gut. It's not all oxidative stress or mitochondrial dysfunction. There are multiple ways in which the pathology of Parkinson's disease can start and progress. And I think this has been our big problem. While we try and find a neuroprotective disease modifying approach to Parkinson's disease based on the concept that all these patients we push into clinical trials are the same, we're not going to find anything. And it could be that we've already done clinical trials where a proportion of patients have improved with a single treatment, but we just haven't seen them against the background of the other larger group of patients who've got Parkinson's disease for a different reason and don't improve.
Okay, thank you. There's one last question. Okay. The question is related to Lewy bodies. The question is asked, any drug can remove the Lewy body, or any research are undergoing in this area?
Right. Okay. Not removing Lewy bodies, as far as I know. Trying to remove the alpha-synuclein, which is in Lewy bodies, that's for sure. But Lewy bodies are not just full of alpha-synuclein. Lewy bodies are full of lots of other proteins and other material also. And I think we still haven't worked out whether Lewy bodies are part of the pathogenic process, so they're a cause of neuronal death in Parkinson's disease, or whether they are in fact formed as an attempt by neurons to protect themselves against toxic species which are being formed within the cells. And I put up a slide that said, or rather, I think I said in the lecture, I don't really understand how alpha-synuclein handling goes wrong in Parkinson's disease in most Parkinson's population, because you can understand what goes wrong in those who have a genetic form of Parkinson's disease linked to alpha-synuclein mutations. But what is driving the mishandling of alpha-synuclein and its packing into Lewy bodies in the vast majority of people with idiopathic Parkinson's disease? And I don't think we know that. And my worry is that alpha-synuclein may be the bullet, but it may not be the gun, and the gun may fire other bullets as well as alpha-synuclein, and we might be fooling ourselves. And so far, we've spent 25 years looking at alpha-synuclein, and I'm not yet convinced that alpha-synuclein is the answer to curing, in inverted commas, Parkinson's disease.
Okay, thank you. Initially, I want to finish the session with the previous question, but one very interesting question or practical questions coming from Dr. Paul Jiang. The question is, do you need any special nuclear imaging to make multimodal approach more logical? Okay.
That would be lovely if you could do that in routine clinical practice. I think at the moment it's beyond our capabilities, beyond your, for every patient to go through that sort of assessment. But that's where you'd like to be in the future. That's certainly, you'd like to be looking inside individual patients' heads to look at which neuronal systems are affected in that particular patient. I think that would be absolutely wonderful. And I have this vision of the fact that every time a patient comes into your consulting room, you put this metal hood over their head and you can image their brain there and then during that consultation, and you can look at these things, and it will come, it will happen, but it won't happen in 10 years. But that's the sort of thing that will make the future treatment of Parkinson's disease completely different from what we have now.
Thank you. Very interesting comment.
And can I just finish by saying congratulations to the Hong Kong Parkinson's Foundation on their 20th anniversary. Very well done, and I hope to visit you in the future.
Yes, we hope that by the time we have the 30th anniversary, you will be invited to come.
No, I'll probably be dead by then.
No, people can live up to 100, right? Okay, thank you very much. On behalf of all the audience, I give you a big clap for your excellent talk.
Thank you very much.
We finish our session now because the other people are waiting for the next one. Thank you very much.
Thank you very much indeed. Thank you.